Well, we're going to start, okay? Good evening, everyone. My name is Roxana Levine, and I am a member of Congregation Beth Shalom and of CBS Sisterhood. I'm also a member of the Lila chapter of Hadassah. This session is titled Hereditary Cancer in the Jewish Community. It's a joint program between CBS Sisterhood, Brotherhood, and the Lila and St. Petersburg chapters of Hadassah. Welcome, everyone. It's wonderful to have such a great crowd. It is my pleasure to introduce our speaker, Dr. Jennifer Permuth, or how she likes to call herself, Jenny. She always emails me, Jenny. I met Dr. Permuth in 2022 when I was searching for information at Moffitt Cancer Center about a surveillance program for pancreatic cancer, since I have the BRCA1 genetic mutation. Dr. Permuth has a background in clinical genetics and molecular biology and worked as a genetic counselor for many years before pursuing her doctorate in epidemiology. She is currently an associate member in Moffitt Cancer Center's Department of Cancer Epidemiology and GI Oncology, and Moffitt's first vice chair of research in GI Oncology. And she is absolutely delightful. You will absolutely love listening to Dr. Jenny. Before we start the presentation, I wanted to encourage everyone to type your questions in the chat and send it directly to me, Roxana Levine. We will get to the Q&A after the presentation, which will take around 30 minutes. And Dr. Permuth will try to get to as many questions as possible within the time of the program. Feel free to raise your hand also at the end. If your question is really long and you would like to actually not type it, please raise your hand and Eileen Barbieri will make sure to unmute you and let you ask your question. So,
Roxana, they might have to chat to me. They might not be able to chat to you.
Sounds good. They won't be able to send it to me?
No, and I'll try to send it to you.
Okay, I'm sorry. So we're going to change it. Please send all the questions to Eileen Barbieri, okay? Dr. Permuth, please, the desktop is all yours. Thank you.
Great. Can you tell me if you can see the large slide, or do you see a large slide and another one with it?
You need to put it in full view.
Okay, so it's hard because there is a bar at the top of my screen that I'm trying to move and cannot. This is different than our practice time. One second. Sorry, everybody.
Do you want to do a slideshow?
Oh, yeah. Okay, one second. It's just...
Okay, I can tell you where you're... Okay.
We good?
Nope.
Yes.
There we go.
Okay, wonderful. I'm glad you can see the full screen. Well, thank you so much to Roxana for inviting me here, and to the Hadassah group and the Congregation Beth Shalom for having me. I'm really excited to talk to you today about hereditary gastrointestinal or GI cancers in the Jewish community. And I thought the best way to start out is to tell you a little bit more about myself, personally and professionally. So I am the daughter of two educators. On the left side of the screen is my dad, Steve, and my mom, Jackie. Jackie taught for Hillel for multiple years, and Dad is a former dean at USF. He's got his doctorate in education. In the middle of the picture here, we see myself and my younger brother and older sister. I'm a single mom of two boys, Joey and Jacob. I have a nephew, Nate, and two nieces who are the daughters I never thought I'd have. They resemble daughters to me, Sydney and Gabby. So family is at the core of my being. Early in my career, my background is in biology and in Spanish, actually, and I got both of my bachelor's degrees at USF, and then went to the University of Minnesota. That's where my family roots are, in the Twin Cities, where I obtained my Master's of Science in Clinical Genetics. And I was a genetic counselor for many years, trained to look at family histories and try to figure out why conditions or if conditions were running in families, and I specialized in cancer genetics. After that, I loved what I did as a genetic counselor, but I felt I wanted to do something more far-reaching. So that's when I got my doctorate in epidemiology, which is really the study of diseases and why they occur. I wanted to develop a skill set to be able to design studies to aid in prevention and early detection and treatment efforts for cancer. Early in my days, I did a lot of research in ovarian cancer and breast cancer, but then transitioned my work to the gastrointestinal system. And ultimately got my doctorate in molecular epidemiology, and have spent most of my career to date focused on pancreatic cancer, and I'll be talking to you about a lot of that today. I also wear other hats. I think I'm a really big patient advocate. I do a lot of lobbying at the state capitol, as well as nationally. I've been on Capitol Hill fighting for what we call recalcitrant cancers, those that have the most fatal disease rates. A couple years ago, I was approached by the main surgeon involved with gastrointestinal oncology at Moffitt. He was the chair of our department, and said, you know what, I would love someone to co-lead research efforts in our department and really shape where we need to go. So that is when I was appointed vice chair of research in the gastrointestinal oncology department. We are one of the biggest on campus. We see about 1 in every 5 patients. So here's a picture of our team. A drone took this, and this is only part of the team. Cancer is something that has touched me not only professionally but personally. The Permuth family has had our own battle with cancer. My dad has had a precancerous lesion of his pancreas, and then my sister back in 2020 was diagnosed with metastatic colon cancer. It was dismissed by our community physician up north. And after a 2.5-year battle, she passed away in 2022 in her early 40s. So this has hit me hard, and we learned, even though we didn't have any red flags for it, that her cancer is part of a hereditary cancer syndrome. So I'll be touching on that today. So more than ever, I understand the subject matter and how important it is for us as Jewish individuals to know about our heritage, to know about conditions that can run in families. So for tonight, I'll be going through information about GI cancers and their potential causes. I'll talk about genetic counseling and testing for hereditary gastrointestinal syndromes, who should have it, when, why, how, what's involved. I'll talk about implications for the Jewish community. And I'll ultimately talk about how we can protect our own health and that of our family. And then I want to give you an inside scoop on some new initiatives related to GI cancer research that I'm spearheading along with my colleagues at Moffitt and in the state of Florida. So these are the latest statistics from the American Cancer Society, which basically show in this year alone, we're going to see about 2 million cancer cases in the United States, and about 18% of them will occur in the digestive system. So the digestive system has the second highest proportion of cancers that are going to occur this year. And when I talk about the digestive system or the GI tract, I'm really talking about the esophagus, all the way down to the anus and all of the organs in between. And in the digestive system, the most common type of cancer affecting Americans is colorectal cancer, followed by pancreatic, and then liver and hepatic bile duct cancer. And those are the top 3 cancers that we see at Moffitt Cancer Center. And when we look at statistics this year, in 2024, they mimic what we've seen in past years, except they're kind of rising in terms of the number of new cases and deaths we are expected to see from gastrointestinal cancers. You know, in this top portion of this graph, we can see it's broken down by biological sex. And amongst males and females, we see there's going to be a lot of cases of colon and rectum cancer. And the same can be said about pancreatic cancer, which is really a rarer cancer compared to all these others that we're seeing on here. And in terms of deaths that we expect, colorectal cancer deaths are going to be high, as are pancreatic and liver and intrahepatic bile duct. and this is across gender. So this is very concerning, and that's why I feel as a community we need to be armed with knowledge about the signs and symptoms of these diseases and what we can do about them, and importantly, if these may be if we may be predisposed to them in our families. The other thing that's really concerning, as was in the case of my sister, is that early onset GI cancers are on the rise. And we're seeing this not only for colorectal cancer, we're seeing it for stomach and pancreatic cancer too. Just to orient you real briefly on these graphs, on the top, we're seeing what we call SEER incidence rate. So this is like new cases in the population according to National Cancer Registry data. And this is for ages 65 to 74. And that's when most people, if they develop cancer, it's later in life. What we're seeing for colorectal cancer, with all the screening that's been happening with colonoscopies, rates are going down in the older, or the population, I should say, over 50. But what we're seeing below that on the lower graph is rates in individuals less than age 50, and they are definitely going up, and it's a huge concern. And part of the reason why the age of colon cancer screening with colonoscopy got shifted to 45 was because of this trend, but I think it really may need to go even lower. My sister's diagnosis was around age 42. Stomach cancer, we're seeing similar things, and with pancreatic cancer, we're seeing trends rise in all ages, especially in young women and in the African American population. So this is certainly something we're watching, certainly something we're seeing in the Cancer Center. This is a nice paper that came out last year that talks about possible reasons why early onset cancer may be on the rise. And it really points to a lot of lifestyle factors, such as high body mass index. So individuals who are overweight or obese may have an increased risk to these diseases. Same as tobacco use or smoking history, alcohol consumption at a heavy rate, glucose levels, and if there's a history of diabetes in oneself, especially a new onset of diabetes in our lives, we need to pay attention to that. Having a lifestyle that is more sedentary, people are not physically active, that's a concern. And then you can see some of these other factors listed here. What's not listed here, though, are things that we can't do anything about, and that's our genetic makeup. We're born with that. We can't change that. But I would argue that there are lifestyle modifications and screenings that we can do as a population. One of the biggest, mistakes some people make is thinking that only a proportion of cancers are genetic. And in fact, cancer is a genetic disease occurring over time due to mistakes or what we call mutations in cells of the body. But not all cancer is hereditary, which is the focus of what we're going to be talking about today. But just real briefly, this top graph, or this top part of the figure, shows that in our body, certain cells, be it in my pancreas or my colon, over time, they can get these blue dots, which are mutations or abnormalities in them. And through time, those can replicate themselves. And over time, a tumor can develop in that particular organ. But with hereditary cancers, it's a little bit different. An individual is born with that mistake, inherited from mom's egg or dad's sperm, and it's in every cell of that body. So that's like a first hit, we call it in genetics, and it doesn't take as much work or as many mutations in other cells to develop a tumor. And usually when those happen, it happens earlier in life, and it can happen in multiple organs, as we'll talk about today. But bottom line here, all cancers are genetic, but not necessarily hereditary or passed down. What we do know is that about 10% of gastrointestinal cancers are hereditary, meaning we're born with the predisposition, it's passed down in a family from generation to generation. And in genetics, if we remember back to those days, we hear about different patterns of inheritance. And in our Jewish community, we learned a lot about Tay-Sachs disease and Gaucher and different diseases that we have carrier testing for when we're getting ready to get married and have kids. Those are inherited in a different pattern. It's called a recessive pattern, where these cancer predisposition genes are usually inherited in what we call a dominant pattern. So if someone harbors that predisposition, there's a 50-50 chance with each child that it could be passed on. Familial cancers mean that it's likely a combination of some genetic factors, maybe some weaker genetic factors, as well as lifestyle factors that are contributing to cancer in a family. And sporadic cancers mean that it's probably mostly environmental in nature. Doesn't seem that there are strong hereditary factors involved. And you can see on the left here, one of our biggest risk factors for cancer is our age. We've talked about body mass index, diet, exercise as playing a role as well. Certainly, we know tobacco exposure is something we should avoid for most, if not all, cancers. When we should expect hereditary cancers in a family is when we see the following red flags. If there's a young age of onset, typically less than 50, that's a red flag. So when Rachel, my sister, was diagnosed less than age 50 with colorectal cancer, in the absence of any other cancer in my family like that, that was a red flag to me that we needed a closer look at things. Multiple generations of cancer in a family in the same bloodline, so say on mom's side or on dad's side, is a red flag as well. Multiple individuals with the same type of cancer, especially if it's young onset disease, that's a red flag. Rare types of cancer, such as male breast cancer, can occur in hereditary families. Individuals can have multiple cancer diagnoses. So we've heard of the BRCA genes and breast and ovarian cancer occurring in those families or in the same individual. Those are things we should be thinking about as we think about our family histories. And importantly, high-risk racial or ethnic groups, such as the Ashkenazi Jewish population. So what's unique about the Ashkenazi Jewish population, and I could say this about other communities as well, such as the Amish or Icelandic community, is that there are common descendants from hundreds of years ago that we can trace back to certain geographical areas. These are founders, if you will. And this schema here is basically showing this one individual, this male, who has one of these genetic abnormalities or mutations. And through time, because of commingling or marrying within the same Jewish community, these mutations that in that founder population, that original population, can persist and can migrate from generation to generation, such that the prevalence of that mutation is more common than in the general population. And a perfect example of that is in the BRCA1 and 2 genes that we've heard of that predispose to breast and ovarian cancer and other cancer types. So in the general population, not of Central, Eastern European Jewish ancestry, the likelihood of having a mutation in one of these genes is about 1 in 400. But in the Jewish population, it's 1 in 40. People often ask about the Sephardic population. Certainly there are founder effects there, but they're not as prominent as what we see with the Ashkenazi Jewish population. I know this community is very well informed, and we know that the lifetime risks of breast cancer are quite high in these families, as are the ovarian cancer risks. So this is just showing an example of, you know, if a woman has a BRCA1 or 2 mutation, the lifetime risk of ovarian cancer can be up to 54%, whereas people in the general population have about a 1.4% chance of developing ovarian cancer in their lifetime. So it's quite high. As I was alluding to earlier, male breast cancer can occur in these families. So if we see that, especially in an Ashkenazi Jewish family, if we see breast cancer less than age 50, if we see pancreatic cancer in an Ashkenazi Jewish family, that's something that should be followed up on. Melanoma can also occur in these families, as can prostate cancer. I will say, though, prostate cancer is quite common in the population, so that's not as big of a red flag, if you will. I had talked to Roxana about moving beyond BRCA just to, enlighten this group that there are other hereditary predispositions out there that we need to be thinking of. But what I will say as the punchline, though, is I think we're learning more and more each day about how these genetic abnormalities that are hereditary, how more common there are in the Jewish population. There is nothing striking that comes to mind in addition to BRCA1 and 2 that I'll be talking about today, but certainly we can see other mutations and other prominent cancer susceptibility genes that I'm going to be talking about today. What's been happening historically is most individuals of Ashkenazi Jewish ancestry have been tested for BRCA1 and 2 and not other genes. And we're finding these days that when we expand and we look at other genes that can predispose to cancer, we're finding more spelling mistakes or mutations. So I think that is one of the things I'll be talking to you about today. If you have not gone for genetic counseling and testing, one of the things that may come up is something called panel testing, and I'll be talking about that in a moment. But as we move beyond BRCA1 and 2, when I think of hereditary cancer syndromes and I think about increased risk to gastrointestinal cancers such as colorectal or gastric or pancreatic cancer, there are a subset of genes that I think about. And I'm not here to go ad nauseum into these things, but I think about the red flags that I introduced you to a couple slides back in different syndromes that can occur in families. So BRCA1 and 2 is part of what's called hereditary breast and ovarian cancer syndrome. In those families, pancreatic cancer risk can be quite high, up to a 10% lifetime risk, as an example. So that's the main GI cancer involved in that syndrome. One of the main syndromes that I think about when I think about hereditary GI predisposition is something called Lynch syndrome. And that is actually what segregates in my family. And I don't know that Jewish ancestry really had anything to do with it. There are some reports of Ashkenazi Jews having, mutations in these families, but certainly not what we're seeing with the BRCA preponderance of mutations and the founder effects there. But in these families, there's a certain set of genes that can be tested for, and this tells us about a very high risk of colorectal cancer. It can be up to an 82% chance in one's lifetime, so certainly affects both men and women. There can be risks of pancreatic cancer, as well as gastric cancer, as well as what's not featured on here are some important gynecologic malignancies like ovarian cancer and endometrial cancer. So if this cancer syndrome is running in the family, men and women in the family want to know about it, and the cancer risk can come on really early, less than age 50. So in these families, if you're seeing early onset uterine or endometrial cancer, or you're seeing ovarian cancer, it may not always be BRCA1 and 2. So we really need to think about the cancer types and the appropriate screening. So that's one reason why genetic testing can be really helpful in families, Jewish ancestry or not, to look at Lynch syndrome, especially if there's colon cancer at a young age in the family. If there's tons of colon polyps, like I'm talking like hundreds, that can be indicative of a condition known as FAP, familial adenomatous polyposis. This is something that a genetic counselor would talk about if they are seeing reports of that in one's family. There's a certain condition called attenuated FAP. That's what's alluded to here. And there's one particular mutation that can be prevalent in Jewish families. It doesn't cause tons of polyps like I was just talking about, but it can increase our risk of colon cancer. So that is something, if one went to a genetic counselor, if there's colon cancer in the family, maybe not at an incredibly early age, but there seems to be a tracking of colon cancer, that would be one thing that a genetic professional should consider. There are other cancer syndromes featured here. I just want to point out a couple. We have a clinic at Moffitt for individuals who may harbor a predisposition to gastric cancer. They typically have mutations in a gene called CDH1. In those families, there's also female breast cancer as well. So that again, think of things in one's family, and when we see constellations of breast and gastric family, we may think of that predisposition. So if we knew about that, for the younger individuals in the family who may harbor a predisposition to that, we want to get mammograms early. We want to get upper endoscopies and screen the stomach as early as possible. There are other syndromes that I'm not going to go through, but the point here is it's not just BRCA that needs to be considered most of the time. This is an example of screening recommendations that would be discussed as part of medical management if someone harbors a predisposition to hereditary gastrointestinal cancers. So as I was just alluding to with the example in my family of Lynch syndrome, remember, colon cancer, female cancers, upper GI cancers, pancreatic cancer. I'm getting colonoscopies every year. I'm getting upper endoscopies. I'm getting MRIs of my pancreas. And, you know, some women in these families may choose to have total removal of their ovaries and uterus. And that can sound scary. If childbearing is complete, it is a very real option for women in these families that I've counseled about over the years, and I've faced myself with my sister and with my mom, who the predisposition was inherited from. And mom is a healthy, she'd kill me if I told you her age, but she's a healthy 70-some-year-old, no cancer in herself, no cancer in her parents. And we inherited Lynch syndrome from that side of the family. So it just goes to show, sometimes you don't see this clearly tracking in families, and sometimes it may not express itself till a certain generation. So there's lots that's yet to be known. I'm just showing you this because I feel knowledge and management of our conditions and our risks can bring power to an individual, and that power can come through means of screening or surveillance, or it can come through preventive surgery, or it could come through, in a perfect world, some natural compounds one could take to reduce their risk. I know I was saying I have half an hour to talk. I do have more slides, so I'm just going to keep going, but we'll have plenty of time for questions. So getting to cancer genetic counseling and what it is, bottom line, it's a process that aims to educate individuals and their families about heritable risk of cancer, help individuals and families derive personal meaning from the information, and empower individuals and families to make educated, informed decisions about testing and their medical care. What happens during such an appointment? These days, they can be virtual or in person. An individual completes a family history questionnaire online or over the phone prior to an appointment. A genetic counselor takes what we call a pedigree. It looks like this. Circles are females, squares are males. And then lines between them show relationships. So this is a woman and her partner, and then their children, a son and a daughter, and then their partners, etc. So this is how a genetic counselor can look at patterns in families and see if it looks like cancer tends to run in families, or maybe there are some environmental or lifestyle exposures at play. Support is provided, genetic testing can be ordered, and referral to other services can be made, such as having a colonoscopy or getting a mammogram if someone hasn't done that and it's indicated. These days, what we have now is not what I had when I was a genetic counselor over 20 years ago. These days we have something called multi-gene panel testing, and I really recommend this if an individual is, I'm just being honest, of Jewish ancestry or even from the general population. I want to know more than what's in the BRCA1 and 2 genes. As I just described to you, I come from a family where we didn't see a striking history, and we have a defect in one of those genes causing Lynch syndrome. We wouldn't have known about it unless I insisted on this multi-gene panel. Here you simultaneously analyze many genes at once. It's faster and cheaper. It typically is covered by insurance, and typically you don't leave any stones unturned. You would hate to test only for a certain subset of genes, and then lo and behold, years later, someone is diagnosed with a cancer that is likely caused by a mutation in one of these genes, and you wish you would have known that. So this testing can be very valuable. Typically, there's a laboratory called Ambry that we work with at Moffitt who does a fine job of getting these results back as quickly as possible. How does testing happen? It's usually an informed consent process where someone signs information that says, yes, you've educated me on this testing. I know the benefits and the limitations of it. Typically, it is a blood sample or saliva can be drawn as well for this test. Typically, results are back in a couple weeks, and they can be reviewed with a genetic counselor via Zoom or phone. Possible results can be threefold. A positive result means the patient was born with that mutation and there's an increased cancer risk. It can also tell someone with a cancer diagnosis, this is likely why it occurred. And sometimes when we find that abnormality, there can be huge treatment implications. For example, if a woman has, say, ovarian cancer and has a BRCA mutation, she may be eligible for something called PARP inhibitors that she may do really well on, whereas someone in the general population who doesn't have a BRCA mutation may not. The same could be said about pancreatic cancer in that class of drugs. We hear a lot about something called immunotherapy these days. People who have Lynch syndrome typically may respond well to that because of the genetic defects. So it's very paradoxical, but it's really important for the treatment of the individual to have this information. And typically with genetic testing in families, if there is someone who has had the cancer diagnosis you're concerned about, if they're still living, it's best for them to go forth with the testing, and then other family members can test depending on their test. It's like looking for a mistake in a chapter of a book. Once that mistake's found, you know exactly where to look. So a person can have a positive test, they can be a negative test where no mutations are found, or sometimes we can have a variant of uncertain significance, which means just that. We found something, but we don't quite know if this is something that is concerning or not. Implications are what I just alluded to. It can help with medical management and options and the intervals for those options, and it can help with what we call cascade testing for other family members. Remember, I said if someone has that predisposition, there's a 50-50 chance they could pass it on to their offspring. So that is why it's very important to know about this in a family and to share this information with relatives. At Moffitt, we have this service. We have these days about 9 genetic counselors. There were 2 when I was around doing counseling. I've got a phone number that can be passed around to you, an email number to call if someone wants an appointment. And if you have family members that live outside of the Tampa Bay area, there's a link I've got for how to find a genetic counselor. But this is located on our McKinley campus, which is right near Busch Gardens, the counseling services here at Moffitt. I wanted to share a little bit about the neat things we are doing in research at our institution and things that I've been very passionate about. So I established something called the Florida Pancreas Collaborative back in 2015. It's the first statewide initiative that has brought together clinicians and researchers from institutions all around our state with one common goal. It's to advance pancreatic cancer research. So I've pioneered that, and my research portfolio is in 2 main areas: early detection and prevention. I firmly believe that the best way to beat this disease is to prevent it in the first place or detect it as early as possible. So that's what I'm committed to doing. The other area that I'm committed to is addressing cancer health disparities. Pancreatic cancer is a disease that we see a disproportionate burden of which in the African American population. We also see higher rates of pancreatic cancer in the Jewish population, and this is likely related to the BRCA genes, particularly BRCA2. So that's why we need to be looking out for that if we see pancreatic cancer in our families. One of the big things that I've been pushing at the Cancer Center is cancer prevention and interception mentality. I feel that this should be at the cornerstone of everything we do at our Cancer Center. as the football analogy really shows, interception is a way of combating cancer by slowing it or halting it in its development. Our population in Florida is older than ever. We expect more GI cancer cases and more survivors for these diseases. So I think we need to be proactive and catch cancer before it develops in its infancy. It's better to treat because it's less complex at the precancerous stage, and people have better outcomes. We know with gastrointestinal cancers, there's many precursor lesions. So we know about colon polyps and colon cancer, right? But with each cancer type, I could talk about precancerous lesions that we should be arming ourselves knowing about so that we can intervene. What my area of interest is in pancreatic cancer are these lesions called intraductal papillary mucinous neoplasms, or IPMNs. These are very common cystic lesions that can really lead to pancreatic cancer at some point. And they are incidentally found in the population at the time of MRIs or CT scans for unrelated reasons. That's what happened to my dad. So my dad was found to have these precancerous pancreatic lesions. So it's very, very concerning because there's no good way to find out if they're aggressive or if they're more indolent and, kind of can be watched for some time. So a lot of what we know about pancreatic cancer is we got to intervene. Several years ago when I took my leadership position, I had the idea of developing the first-in-kind Pancreas Interception Center, or PIC, where we aim to prevent pancreatic cancer before it develops or detect it as soon as possible. We want to do this. We want to focus on interception because pancreatic cancer will soon be the second leading cause of cancer deaths in the U.S., and this is behind lung cancer. It's typically diagnosed in an advanced stage. That's like 85% of the time when survival is poor. Effective strategies for early detection, prevention, and intervention are lacking. What are the risk factors? We've talked a bit about family history. We know diet can play a role. Lots of red meat products are good to stay away from. Processed foods. Obesity is a risk factor. We've talked about race. Ashkenazi Jewish background and African Americans have higher risks. Smoking history is a strong risk factor. Historically, men were more often diagnosed with pancreatic cancer than women, but now we're seeing an uptick in young onset females with pancreatic cancer. Diabetes, if anyone notes a recent onset of diabetes, pancreatic cancers can be diagnosed within several years after that. So that is a big sign to report, to talk about with one's physician so one could be monitored closely. Pancreatitis or inflammation of the pancreas is also something that can be a risk factor. And then as I just talked about, these premalignant pancreatic cysts, which I'm showing an example of right now, are risk factors as well. So I wanted to design a clinic where we have specialists that offer a one-stop shop. This is Dr. Mock. He is an advanced endoscopist and a functional medicine expert we hired at Moffitt a couple years ago. He's my own doctor. Love him. I was one of our first patients in this clinic. I wanted a multi-pronged approach to help me and to help my family. I wanted us to be able to identify at-risk individuals. So these are people with the risk factors that I was just talking about, particularly those with an inherited predisposition and these precancerous cysts that I've been talking about. We want to provide education, offer increased surveillance for the pancreas. That usually is done with an MRI, something called an MRI MRCP, or we can do endoscopic ultrasounds of the pancreas in a surveillance mode. And then depending on a hereditary cancer syndrome that may be in the family, there could be other organ types we need to look at and survey. So Dr. Mock helps to really coordinate my care. He also recommends a lot of lifestyle interventions for me, like turmeric as something good that's an anti-inflammatory, a lot of mindfulness exercises. So a lot of really good practical information. He's big into natural agents as well. What's important about the PIC is that Dr. Mock has a bi-weekly tumor board or PIC board where we discuss cases and what's the proper medical management for them. And certainly we want a research component to what we're doing, and that's an area that we need to obtain funding for. I wanted to share with you one of my grants. It is a big grant from the National Cancer Institute where we're trying to differentiate between those pancreatic cysts that pre-treatment we can pick out and determine if they're aggressive or not aggressive. So using an approach that I've come up with that looks at blood-based markers as well as some imaging features that are naked to the radiologist's eye, we feel that the future state is being able to more clearly and non-invasively signal danger, whereas currently it's hard to do so. And I know I harbor these pancreatic cysts. I wish I had something that could tell me, hey, these are really concerning versus they're not as much to worry about. So if you're interested in a study like this or being part of that Pancreas Interception Center, there are email addresses and phone numbers I can provide you with. The other thing we've got going on in Moffitt is the first chemo prevention trial. So this is for individuals with pancreatic cysts who were trying to slow progression to malignancy. There's a natural vitamin E compound that my colleague Dr. Malafa is studying, and he was just awarded a large-scale grant for that. My dad is alive about 13 years after his diagnosis. He's had these cysts and was in an early phase study of Dr. Malafa's and is doing well these years later. So finding these cysts and managing them, I truly feel is a holy grail for pancreatic cancer early detection and prevention. To get to Mount Everest and plant a green flag, I think we need key people, technology, and partners. So those are all things we're working on. The other thing we're working on is being part of international consortium. We're part of an international group called PROCEED, where if someone has a hereditary predisposition to pancreatic cancer or has one of these pancreatic cysts, they could be part of this research. So we provide kind of a gateway to studies. The other thing that I've got up my sleeve that I've been working really hard on is a large-scale vision. Our Pancreas Interception Center is part of my larger vision to develop the first of its kind center of excellence in gastrointestinal oncology in the United States. And I think I've spelled out to you the rationale why. These are common malignancies. They're common causes of cancer deaths. We see a lot of them at Moffitt, and we got to change the paradigm. So by building this, what we hope to do is improve outcomes and save lives, gain more visibility for the types of research we're doing at Moffitt, increase the number of patients coming in the door, continue to attract the brightest individuals and scientists and clinicians to come to our center, and allow us to develop industry partners and philanthropic partners to help fund this type of research. So out of today, I'm hoping that I've shared with you, it's important to listen to your body. If there's any changes in bowel functions, unintentional weight loss, bloating, abdominal pain, nausea, vomiting, that goes on for more than a couple weeks, talk to your doctor. If you note this in a family member, rectal bleeding is a big sign of colon cancer. A lot of the times it's misdiagnosed as hemorrhoids. Family members need to tell their doctor. Know your family history, be proactive about your care. I've talked to you about the benefits of genetic counseling and testing for oneself and one's family. And then I wanted you to know there are some big initiatives at Moffitt in terms of studies that, if you're eligible, you're welcome to take part in. Everyone is welcome to become a patient at Moffitt for surveillance, or if you are undergoing active treatment and are elsewhere in the community, we are a home for the community and feel we provide really compassionate quality care. If there are other things that you want to do, increase awareness of the importance of what we've talked about tonight. And if you're ever looking for a place to donate, what's cool about Moffitt and our department is 100% of every dollar goes to the research that we do. It's not like it pays for overhead costs. So I directly oversee our funds. So we feel knowledge is power, and there's a lot we can do together to try to improve outcomes in lives. So this was meant to be information that could be helpful and hopefully empowering. Thank you for your time, and I want to just open up the floor to questions now.
If you don't mind, Eileen, could you actually let us, okay, I can see everyone, but first of all, I want to personally thank Dr. Permuth. I knew that she was vibrant and knowledgeable, but I didn't know how wonderful of a speaker she was going to be. So a wonderful surprise. And I 100% agree that knowledge is power. I personally want to tell you that Dr. Mock is also my doctor. And I left my GI behind too. I absolutely adore Dr. Mock, has been my doctor for the last year and a half through my surveillance pancreatic cancer. So since I didn't see any questions in the chat, I want to open it to anybody that would like to, ask any questions, because we do have 10 more minutes.
Oh,
So,
Roxana, we do have
yes.
a question.
Yes, let me see.
I sent it to you.
Okay. So this is a question. Do you recommend routine genetic panel for all Ashkenazi Jews? And if so, at what age? And is it covered by insurance? And if not, family history of cancer yet? Okay, let me rephrase this. Do you recommend routine genetic panel for all Ashkenazi Jews? And if so, at what age? And is it covered by insurance? If there's no family history of cancer.
If there's no family history of cancer, I think it's a personal decision. I'm more direct these days, and I would say look into it, go for it. I think in the case of, my family, as I've shared with you, there was nothing striking going on, and I'm glad to know this information. In terms of what age, I think, this is pretty serious information. I wouldn't recommend that a teenager do this, but I would say maybe 20, 25 would be an appropriate age to have the testing. Again, we prefer to test someone who's had a cancer in the family as opposed to someone who's unaffected, who has not had a cancer diagnosis. But in some of these families with a hereditary predisposition, 25 can kind of be the magic age to start with mammography or colonoscopy, etc. So that's why getting in the door earlier than later can be beneficial.
Thank you, Dr. Permuth. If you don't mind, instead of me explaining, could you tell our panel here what it consists a surveillance of the pancreas, so people know exactly what it means?
Absolutely. So surveillance of the pancreas involves imaging, typically endoscopic ultrasound. So a probe goes down the throat, someone's under anesthesia, and the probe looks internally at the pancreas. If there is anything that looks suspicious, then a biopsy can be performed at that time. It's usually called a fine needle aspirate or a fine needle biopsy. Usually we alternate that every other year with an MRI, so magnetic resonance imaging, and there's certain sequences of scans they can do to get better looks at the pancreas. So the imaging combined with blood work, typically CA19-9 is the marker that we look at for pancreatic cancer, but unfortunately that is usually elevated very late in the disease and not necessarily with an early onset to disease. So that's the concern with that marker. So we definitely need more blood-based markers for pancreatic cancer. The other things to be aware of is just knowing our medical history. So usually Dr. Mock for the PIC will make sure to order hemoglobin A1C, for example, just to look at glucose levels and make sure that someone is not pre-diabetic, which could be a risk factor or a sign of pancreatic cancer. So things like that, just knowing one's history, knowing changes are part of it. And I think lifestyle modifications and in terms of surveillance, things that I'll be looking into are chemopreventive agents. So this vitamin E compound sounds intriguing to me, and other things that we may learn about in the coming years in terms of natural compounds are things that I think are important to know about for people who have higher than average risks.
Thank you. A very good question. How accurate is Cologuard? If somebody's asking.
Well, accurate is Cologuard. You know what? I think I wish I knew the numbers offhand. It's certainly more accurate for a later stage colon cancer. My concern is that it may not pick up polyps that are concerning, which are typically adenomatous polyps, and I'm not quite sure of the sensitivity and specificity of early stage disease. My concern is it could give a false awareness that everything is fine, and maybe there is a hidden or what we call occult cancer or a concerning polyp that we're just not able to detect with Cologuard. So if it's a high-risk family, a family with an inherited predisposition, young onset disease in the family, I would not recommend Cologuard. I would go for the colonoscopy.
Wonderful. And in terms of recommendation of dietary advice or changes, if one is susceptible to gastrointestinal issues.
Can you repeat that, Roxanne? I'm sorry.
Yeah. What are some dietary advice or changes? You mentioned the red meat, for example, but if somebody is susceptible to gastrointestinal issues, which kind of changes or dietary advice you would recommend for those kind of things?
Great question. Typically, a Mediterranean diet is something that a lot of professionals recommend, including Dr. Mock, because it's got a lot of anti-inflammatory properties, omega-3 fatty acids, which are typically very good for the body, lots of fruit and vegetables, less of the red meat products, less processed foods. I think a lot of our artificial sweeteners are a concern, so staying away from those and excess sugar.
Wonderful.
Yeah.
Somebody asked how they can actually, if they can have an exact address to make a donation. And I believe you are going to send me a lot of resources so I can share with everybody that signed up for this.
Yeah, I appreciate that. Yeah, typically the way I like to know about things, so I can thank people. So, including me and our philanthropic advisor, I can get you that information for how to do that. And everything's tax deductible as well, which is really helpful. So thank you for asking that.
Sure. Does anybody else? I don't see any other questions.
One more question, Roxana.
Yeah.
If someone has a history or presence of fatty liver disease, would you recommend the screening panel?
So fatty liver disease is more and more common these days. I would definitely, and it can be due to our diets, it can be due to stress, it could be due to alcoholism. It's got a lot of different what we call etiologies or causes. But that and Jewish heritage, and if there's cancer in the family, I would talk to a genetic counselor about it. There's nothing to lose in doing that.
Wonderful. Well, I want to thank you, first of all, not just for all the knowledge that you were able to share with us, but also for our community to know that we have this amazing resource center, the Moffitt Center, and your department that can help, diagnose, prevent, and all these diseases that you're talking about. Just personally, I was referred to Johns Hopkins to continue my surveillance before I reached you, that we are so close to such an amazing center. So I think that we all are, very thankful that we know that we can count on you, and you can count on Moffitt Cancer Center to, to continue our, prevention towards cancer. And as a Jewish community, Ashkenazi Jewish community, we need to know all this information, very valuable information. So personally, I want to thank you. And I'm sure on behalf of everybody, the whole Jewish community here, Congregation Beth Shalom, the Hadassah chapters of Lila and St. Petersburg, we are very, very thankful for this hour, for all your resources. And we hope to get all your information by email so we can disseminate it to everyone and anybody else in the community. This Zoom is recorded, so we hope that we can also share with anyone that is interested and was not able to be present today. So thank you so much. Yasher koach.
Yasher koach,
Thank you
Yasher
so
koach.
much.
Thank you. Thank you. Wonderful. Thank you so
Thank
much.
you everyone
Shalom.
for being present today. I really appreciate it. It was a wonderful program, joint program. When we are together as a community, we can be so much more strong, so much stronger. So thank you so much to everyone for being here. And thank you, Eileen, for all your help. Thank you. Thank you, Dr. Permuth, from all my heart.
Bye, everybody. Have a great rest of your
Bye.
night.
Stay
you.
well.
Thank you so
Stay
much.
well. Stay well, everybody.
Bye-bye.
Bye.
That was lots of good information.
Yes, it was.
Overwhelming.
And once the Zoom recording has been downloaded, I'll send it over to Roxana and to the office. So again,
Good.
anybody that's
Thank you
registered
so
should be
much,
able to get a
Eileen. Thank you
copy.
so much. Thank you, Cindy. She's such a sweet lady. I love her. She's a heart. This is a sweetheart. So I'm glad we had a good group. And thank you, everyone, for all your help. And be healthy. And Laila Tov. Good night.
Lila Tov.